Hello, everyone, and welcome to today's live broadcast, Significance of Mean Cell Hemoglobin of the Reticulocytes, MCHr, Biomarker in Diagnosis of Iron Deficiency Anemia, presented by Dr. Nita Munshi. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Abbott Diagnostics. For more information on our sponsor, please visit abbott.com. Now let's get started. I would like to remind everyone that today's event is interactive, and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of your presentation window, or you can report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of your presentation window and follow the process to obtain your credits. I'd now like to introduce today's presenter, Dr. Nita Munshi. Dr. Munshi is Professor, Head and Director of the Laboratories at Ruby Hall Hospital in Pune, India. This is a group of specialty hospitals with 750 beds. She also heads the Steering Committee for Quality Control and is the Chairperson of the Hospital Infection Control Committee. She has also authored chapters in pathology books and has presented papers and posters in both national and international conferences. She's very passionate about infection control and hence works closely with infectious disease clinicians. For a complete biography on Dr. Munshi, please visit the Biography tab at the top of your screen. Welcome, Dr. Munshi. You may now begin your presentation.
Thank you. Thank you for that introduction. Hello, friends. As she said, I'm Dr. Nita Munshi from the Ruby Hall Group of Hospitals in Pune, India. My topic today is significance of MCHr in the diagnosis of iron deficiency anemia. At the outset, I'd like to make my disclosure statement, which you can read. Now to begin with the presentation, I'd like to just point out the learning objectives. First, to discuss the global impact of iron deficiency anemia. Second, to describe iron metabolism, absorption, regulation, and storage. Third, review laboratory diagnosis of iron deficiency anemia, including new parameters in laboratory. And last, I'd like to share results of an iron deficiency anemia study performed on the Abbott MCHr analyzer in our laboratory. Now, to begin with, we all know that iron is an essential metal for the body. It is required for hemoglobin synthesis in the erythrocytes, oxidation reduction reactions, and cellular proliferation. Body iron metabolism is a semi-closed system as there is no definitive excretory pathway for iron. Iron deficiency anemia is the most common anemia worldwide, especially prevalent in women and children in regions where meat intake is low, food is not fortified with iron, malaria, intestinal infections, and parasitic worm infestations are common. Women with frequent pregnancies are particularly susceptible. In India, 49% of the population has iron deficiency anemia. Now, just to give you an overview of the global anemia prevalence, about 1.5 to 1.7 billion people are affected worldwide, which accounts for 24.8% of the world's population. Prevalence of anemia is highest in South Asia and Central and West Africa. While the causes of anemia are variable, it is estimated that half of the cases are due to iron deficiency. Now, the table on the left tells us about the age-wise distribution of anemia globally. And as you can see, preschool age children account for the highest number, that is 47.4%, which is equivalent to 293 million of the population affected. The second largest group is pregnant women, which account for 41.8% of the population, accounting for iron deficiency anemia. And then, of course, we have the non-pregnant women. So as I said earlier, the women and children account for a huge proportion of iron deficiency anemia, even globally. Now, this is just to give you a map and a visual impression of global estimates of the prevalence of anemia. This slide tells us in infants aged 6 to 59 months. Of course, this data is of 2011, must have changed over the years, but this is the data that I have. Then this is a slide to tell us anemia in women of reproductive age group, that is 15 to 49 years. And again, we can see a huge prevalence over Africa, India, and the Southeast Asian region. Now, what are the types of anemia? Just to tell you briefly, anemia is divided into the following categories: iron deficiency anemia, anemia of chronic diseases, vitamin deficiency anemia, aplastic anemia, and hemolytic anemia and sickle cell anemia, which fall into the provision of hemoglobinopathies. Now, patients at high risk of anemia, we've already discussed, is women, infants, children, critically ill patients, surgical patients, chronic kidney disease patients, congestive heart failure patients, and of course, chronic cancer patients. So cancer patients, heart disease, kidney disease, all fall into the category, and critically ill patients fall into the category of chronic diseases, and they account majority of the times for anemia of chronic diseases. Now, just to tell you about the WHO guidelines for anemia, because that is taken as the scoreboard or the baseline to diagnose any anemia. In children 6 to 59 months of age, any hemoglobin 11 grams or higher is non-anemia. Mild is between 10 to 10.9 grams per DL. Moderate anemia is 7 to 9.9 grams per DL, and severe anemia is less than 7 grams per DL. For children 5 to 11 years of age, anything over 11.5 grams per DL is not anemia. 11 to 11.4, so this is a very narrow band of mild anemia. 8 to 10.9 is moderate, and less than 8 is severe anemia. And children, so as you can see, children are broken up into 3 categories. One is 12 to 14 years of age, one is 5 to 11 years, and then 6 to 59 months. So for 12 to 14 years of age, anything over 12 grams is non-anemia. 11 to 11.9 grams is mild. 8 to 10.9 is moderate, and lower than 8 grams. So that is similar to the age group of 5 to 11 years. For non-pregnant women, 12 grams or higher is non-anemia. Now here I'd like to just point out that this is WHO guidelines, which is globally prevalent and taken as a guideline for the global scenario. However, in India and some of the Asia Pacific regions, each region needs to establish what is their norm for calling pregnant and non-pregnant women anemic or non-anemic. So as per the global guidelines, it may be 12 grams, and pregnant women 11 grams per DL or higher is non-anemia. 10 to 10.9 is mild anemia, and 7 to 9.9 grams per DL is moderate anemia. However, lower than 7 grams per DL in pregnant women and less than 8 grams per DL in non-pregnant women is considered as anemia as per the WHO guidelines. For men, the guidelines are a little different. More than 13 grams per DL is non-anemia, 11 to 12.9 grams per DL is mild, 8 to 10.9 is moderate, and less than 8 grams per DL is considered as severe anemia. So we do have a benchmarking which we can follow, and then it is up to each lab to establish their own guidelines. Now coming to iron metabolism. Now iron absorption. The site of absorption is usually the duodenum or upper jejunum, which is known to everybody. Now, there are two distinct pathways to iron absorption. One for uptake of heme iron and one for ferrous iron. Most of the dietary iron is non-heme form, which is less than 5% bioavailable. Less than 10% of dietary iron is heme form, and this accounts for more than 25% of bioavailability. Now, just a few things that we need to know when we talk about iron absorption. Transferrin, ferritin, and hemosiderin. What is transferrin? It's the plasma iron transporter protein, which carries less than 1% of total body iron. Ferritin is the intracellular storage of iron, and hemosiderin is the long-term iron storage pool, which is available and seen in the bone marrow, in liver and spleen, and wherever we have iron storage. Now, just a quick word on foods with good source of iron. This is very important for people to know because a lot of patients do ask when we face them with iron deficiency anemia, they do ask us what are the iron-rich foods. So this is just a brief to show you what are the different categories of iron-rich foods. And there are basically 3 groups, Group 1, Group 2, and Group 3. Group 1 is basically for non-vegetarians, which is meat, seafood, and poultry. Group 2 is for the veggies and the vegans, which accounts for vegetables, beans, fruits, and nuts. And Group 3 is breads and cereals, grains. So this is basically, of course, this can be seen anywhere on the net, but this is just to give you a brief on foods rich in iron. Now, when we talk about foods rich in iron, one important factor to remember is we should know factors that influence iron absorption. And here I would like to state that we have to look at inhibitors, competitors, and facilitators of iron absorption because they do influence iron absorption and do contribute towards iron deficiency anemia. Now, the inhibitors are phytates, tannins, which we commonly find in tea and coffee, soil, clay, laundry starch. Iron overload itself is an inhibitor, which is naturally provided in our bodies, and antacids. So these are inhibitors of iron absorption. Then we have competitors, where there is competition to iron absorption, and these are metals such as lead, cobalt, strontium, manganese, and zinc. And of course, we have facilitators of iron absorption, which help in iron absorption. So ascorbate, that is vitamin C, citrate, amino acids do help iron absorption, and iron deficiency itself acts as a facilitator. So just as iron overload is an inhibitor, iron deficiency is a facilitator for iron absorption. Now let me show you a graphical presentation of iron absorption. Now, as you can see in this diagram, what I'm showing is the duodenal epithelial cell with villi. Now, food iron is broken up into 2 parts. One is heme iron and one is the non-heme iron. The heme iron is absorbed through the epithelial cell with a heme transporter and then further broken up and either absorbed as mucosal ferritin or through ferroportin transported and converted from ferrous to ferric and stored in iron storage areas such as blood, plasma transferrin, and also in the liver and marrow. The non-heme iron is either is ferric form and it's reconverted to ferrous at the epithelial surface and excreted. However, a part of it may be taken in through the epithelial surface with DMT1 and absorbed and taken in again into mucosal ferritin and also to ferroportin, which then absorbs the iron, converts the ferrous to ferric, and helps to store it in storage areas. A part of this mucosal ferritin is lost by the shedding epithelial cells. And this is basically summing up the entire process of absorption, storage, and excretion of iron in the body. Now let us have a word on the key regulators of iron metabolism. Hepcidin has now become a prominent regulator of iron metabolism, and we do have analyzers which now monitor hepcidin. The main role is to inhibit iron fluxes into the plasma. Hepcidin binds to the iron exporter ferroportin, which you saw in the earlier diagram, causing its endocytosis and lysosomal degradation, which results in cessation of cellular iron export. When iron is deficient, hepatocytes produce less hepcidin, allowing more iron to enter plasma. When iron is abundant, on the other hand, hepcidin production increases, limiting further iron absorption and release from stores. So thus, hepcidin plays an important role in regulation of iron metabolism. Now, looking at this diagram again, here we talk about iron cycle and storage. Daily absorption of iron is about 1 milligram from the duodenum, which is then transported by transferrin in the plasma and either taken to liver and other parenchymal cells and tissues, especially muscle myoglobin, which is then excreted in urine, feces via nail, hair, and skin. The daily loss is about 1 milligram. We also have storage forms of ferritin and hemosiderin in macrophages. Also from transferrin, the iron is then transported to the bone marrow into the normoblast, and this normoblast help in erythropoiesis and are incorporated into the circulating hemoglobin in the erythrocytes, from where also it is taken by the macrophages. Now, a part of this circulating hemoglobin iron is lost during the menstrual periods and in any form of hemorrhage when we have loss of blood. Now, this slide basically sums up iron transport and storage of iron, and about 1 milligram is what is required from absorption to storage, and the loss is almost balanced to this effect. And it is only when we talk about imbalance in any of this part of the cycle where we will end up with iron deficiency anemia. Now, talking about pathophysiology, there are 3 stages. Insufficient iron supply for hemoglobin synthesis, obviously. Iron mobilized from the stores. And of course, the 3rd stage where stores become inadequate and anemia develops. Now, what are the stages of iron deficiency? There are 3 stages. Stage 1, we have depleted iron stores. This stage is asymptomatic. We would not really see this. The ferritin is low and the bone marrow stores of iron are absent or low. However, in this stage, one rarely does a bone marrow. Low ferritin may be done if a lab or a pathologist or a clinician is smart enough to pick up low indices in a CBC report. Stage 2 is latent iron deficiency, where you have low transferrin saturation, low serum iron, raised serum heptoglobin, and normal hemoglobin. This stage also is latent and may or may not be picked up because the hemoglobin is still normal. It is only the indices which are low. And stage 3 is iron deficiency anemia, where low hemoglobin and low hematocrit with low indices on an iron deficiency anemia report, on a hemogram report, compels the clinician to work up the patient further to prove that the patient has got iron deficiency, and we would further test the patient for ferritin and other parameters. Now, when we talk about laboratory diagnosis, the commonest test asked for is a complete blood count, or a CBC as we call it. When we see a low hemoglobin, low hematocrit, low RBC count, low MCV, low MCH, and low MCHC with a high RDW, we all know, and laboratory people as well as clinicians know, that this points towards iron deficiency anemia. Then we look at a peripheral blood smear, and it shows hypochromia with microcytosis, anisopoikilocytosis, pencil cells, maybe target cells, and we confirm a diagnosis of iron deficiency anemia. Now, this is just to show you a peripheral blood film, what it looks like. The left smear shows us hypochromia with anisocytosis, pencil-shaped cells, and the right slide shows a lot of poikilocytosis, erythrocytes, and this is a classic picture of iron deficiency anemia. Now, once iron deficiency anemia is suspected, biochemical markers are usually asked for by the clinician to confirm a diagnosis of iron deficiency. And what are they? Serum iron, TIBC, ferritin, soluble transferrin receptor, free erythrocyte protoporphyrin, and hepcidin. And we get a low serum iron, a low transferrin saturation, but high TIBC. A low serum ferritin, increased soluble transferrin receptors, increased free erythrocyte protoporphyrin, and low serum hepcidin levels. Now, let me point out at this stage that the last three parameters are rarely done as routine by any lab. Only a very, very specialized lab may do these parameters. A normal or routine or even a high-value lab may do only serum iron, TIBC, and ferritin. So there is a limitation on diagnosis of iron deficiency anemia or its confirmation by biochemical markers. Then we look at the bone marrow examination. Erythropoiesis is usually micronormoblastic because the iron stores of iron are already utilized. There is absence of stainable iron in the bone marrow on Pearl's Prussian blue stain. On the left is the control slide on Prussian blue, which shows a good iron storage. And on the right is iron deficiency, where you cannot see any iron stores. Thus, let's look at the new parameters. Now, we must understand that today we have a lot of new automated analyzers, and they provide us with tests that are independent of infection and inflammation. We all know that ferritin and iron are acute phase reactants and are easily affected by infection and inflammation. And hence, companies and manufacturers have come out with new parameters which are not influenced by infection and inflammation. And they are zinc protoporphyrin, soluble transferrin receptor, reticulocyte hemoglobin content, also known as RET-HE by Sysmex, Reticulocyte hemoglobin content known as CHR by Siemens Advia, and mean cell hemoglobin of the reticulocytes, that is MCHr, by Abbott. So these are some of the new parameters available to us on the new automated analyzers in a hematology lab. Now, one approach would be to identify newly formed iron-deficient cells when they are released from the bone marrow as reticulocytes. Now, these reticulocytes are newly formed independent RBCs, and they would be a very good parameter to analyze because they would be rich in iron content. Flow cytometric analysis of reticulocytes allows determination of the mean cell hemoglobin of the reticulocytes, that is MCHr. Some analyzers may also provide percent hypochromic RBCs, example percent HPO by Abbott, but this is available only as a research use parameter and cannot be used for giving patient results commercially in commercial labs. The percent HPO measure is regarded as a time-averaged marker of iron-restricted erythropoiesis. Now, the lifespan is 120 days for a red cell, and that is why it is taken as a measure for iron-restricted erythropoiesis between 20 to 120 days. But the MCHr is a measure and a real-time parameter which allows us to measure the hemoglobin content in the reticulocyte for up to 48 hours. Now, coming a little more into MCHr, what is MCHr? As I said earlier, it is a mean cell hemoglobin of the reticulocyte. It is determined at the cellular level. Early detection of iron deficiency, also useful for diagnosis of functional iron deficiency, and for monitoring responsiveness to iron therapy and erythropoiesis stimulating agents. Now, this is very important. So in addition to early detection of iron deficiency, we can monitor patients on iron therapy with this. It monitors acute changes in hemoglobin incorporation into the erythron or erythrocyte. It is more sensitive than indirect chemical methods. And compared with erythrocytes, the shorter lifespan of reticulocytes makes this parameter a better biomarker to reflect iron status in the short term. Therefore, MCHr represents an attractive alternative for the diagnosis of iron deficiency, especially in countries with high prevalence, like in India, where I come from. It is more stable. It's a very stable assay, rather. So even if the reticulocyte volume changes due to a delay in sample processing, the MCHr content does not change because, as I said earlier, it is stable for almost 48 hours. Now, I would like to run you through a study that we did at our hospital in our laboratory. And this was basically for our confidence to establish the efficacy and efficiency and importance of MCHr. So what we did is we took a sample size of 50 control group and 50 patients with iron deficiency anemia. It's 50 and 51. Now, the control group was basically patients who visited our health checkup department, were normal, healthy adults, where men had a hemoglobin of more than 13 milligrams per DL, and females had a hemoglobin of more than 12 milligrams per DL. The MCV was normal, MCH was normal, and MCHc was normal. In the iron deficiency anemia group, where we had 51 patients, The hemoglobin for men was less than 13 and for females was less than 12. The MCV was less than 80 femtoliters, MCH was less than 27 picograms, and MCHc was less than 33 grams per dl. So it fulfilled the criteria of iron deficiency anemia, and the biochemical parameters confirmed iron deficiency with a serum iron less than 50 micrograms per dl, a TIBC more than 425 micrograms per dl, and in serum ferritin was less than 10 nanograms per ml. Thus, showing us that these were confirmed iron deficiency anemia population. Then we looked at the MCHr in both the populations, both the groups, that is the control group and the IDA group. Now, as you can see, the control group had a mean MCHr of 31.51 picograms with a range of 28 to 36.4 and a median of 31.4 picograms. Whereas the IDA group had a mean MCHr of 23.41 picograms, a range of 14.7 to 27.5 with a median of 23.15 picograms, which clearly shows us that the MCHr is a very good parameter to measure iron deficiency anemia. Thus, friends, I would like to highlight this with a screenshot of the same one of the patients that we had considered and included in the study, where a CBC with a hemoglobin was 8.12 grams per dl, the MCV was 60.5, MCH 18, MCHc 29.7, and the MCHr was 19.1 picograms. The chemistry showed serum iron of 11, TIBC 430, and ferritin of 7.6. It is important that MCHrs are interpreted in conjunction with other laboratory results. Now, for us, it was very important to establish and gain confidence that MCHr really is a true parameter, and that is why it was very important for us to measure the biochemistry parameters simultaneously so that we could establish and confirm a diagnosis of iron deficiency and then look at the MCHr to gain and to get our own confidence in the laboratory. Then we looked at the economic value, and obviously laboratory cost containment is always an important consideration worldwide, no matter which part of the world you are in, and more so in countries with resource restrictions. Since MCHr can be done on the same sample used for CBC, it is a huge value addition and represents a cost-sensitive screening test for iron deficiency anemia. Reference ranges for hemoglobin content of reticulocytes is dependent on the technology. MCHr reference range is different from both RetHE as well as CHR, and each parameter will have to have a lot of studies to establish what is the reference range. Now, we did only a population study of 50 samples and 50 control group, but we are now going to extend it to a much larger population so that we know and establish our own reference range for MCHr. And it would be my advice to all my fellow colleagues that if you have the option of RetHE or CHR or MCHr, you should establish your own reference ranges. But believe me, friends, this is a huge value addition to us and to clinicians and more so to patients, because in a simple CBC sample, we are able to confidently tell our clinicians that this patient does fall into the category of iron deficiency anemia without subjecting the patient to an extra draw for biochemical parameters. So the TAT is reduced, the patient draw is reduced, and the patient can immediately be started on treatment by the clinician. The TAT for hemograms, the complete blood count, is much lower than biochemical parameters, and the patient can confidently be started on treatment and the patient can be followed up, as I told you earlier, with an MCHr to establish whether the patient is improving on the iron therapy. Thank you, my dear friends. And now I'm open to questions. So please feel free to ask any questions that you would like to. Thank you.
Thank you, Dr. Munshi, for your informative presentation. We will now start the live Q&A portion of our webinar. If you have a question you would like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we will answer as many of your questions as we have time for. Okay, let's get started. Dr. Munshi, we have some great questions coming in. Let's start with this one. How does your laboratory educate physicians on the availability of MCHr and the clinical interpretation of the assay?
Thank you. That's a good question to start off because that's always a challenge for the laboratories. What we do is we usually invite our clinicians at least once a year, if not more often, to the lab to educate them on all the new parameters and new equipment that we have in the laboratory. And then we tell them about the new parameters we've started, like we did with the MCHr. So we do that, plus I send out mails and WhatsApp messages nowadays with social media so that they are constantly reminded of the new parameters that we've started in the laboratory. And we have a very good interaction with our clinicians throughout the hospital. We are a huge hospital, but despite that, and despite having a lot of clinicians, me and my colleagues, we try to maintain a very good network with the clinicians, and I think that has helped us a lot.
Thank you, Dr. Munshi. Now, our next question. How do you convince clinicians to use a cellular marker over traditional chemistry markers that are well known for IDA?
Well, that's another good question. Thank you. See, it is very important when clinicians look at patients, they're looking at cost containment and TAT, two parameters that they're very concerned about. And by providing information from a simple or a single CBC report, if we can give them more information, like I mentioned in one of my slides, that this is a huge value addition, it not only reduces draws for the patient, it also reduces the turnaround time, TAT, because then the laboratory would be able to give information from the CBC, where the runtime is much shorter, than wait for the biochemical parameters, which take longer to churn out. So overall, it's a benefit to the patient and patient care from a clinician's point of view. I think that
Dr.
should
Munshi,
suffice. Are you happy with
yes,
that?
It does. Thank you. How does MCHr compare to the other methodologies to measure reticulocyte hemoglobin available on the market?
Thank you. Very, very important question. Today, we have, I think there are about three equipments in the market which give similar parameters. We have one from Siemens, which gives us what is known as CHR. Then we have Sysmex, which gives the RetHe, or reticulated hemoglobin, and the Alinity from Abbott, which gives MCHr. Now, basic principle of testing remains the same because they all use RNA-based dyes and the flow cytometric method. However, I think what is important is when you look at the normal range in the different methodologies, it is important to know that there is an overlap. I mean, I'm referring to one of the articles which came out in the Blood in 2016 by the American Society of Hematology, which was performed on the XN analyzers of Sysmex, usefulness of reticulocyte hemoglobin equivalent for diagnosis of iron deficiency anemia. There is an overlap in the reference ranges of normal and iron deficiency anemia. The range was 25.9 to 38 with an average of 34, whereas IDA was 15.1 to 35.6. So there is an overlap in the reference ranges. Whereas if you look at the alinity, HQ, the bias in the ranges is eliminated and there is no overlap in the reference ranges between the normal population and the iron deficiency anemia. In the Siemens had also published the article in one of the Turkish journals of hematology. So I think the references are available in the index libraries and in libraries to refer to. But what I see is that we should have a clear-cut difference in the reference ranges between a normal population and iron deficiency anemia, because if there is an overlap, it gets very confusing, not only for the clinicians, but even for the laboratory personnel. So that's where I find the difference. And I find the alinity better as far as the picking up of iron deficiency anemia from CHR is concerned from a CBC report.
Very good, thank you. Could you clarify what the normal range for MCHr is?
By normal range, yes, in a normal healthy population, the reference range, which has been calculated from various studies, is 25.3 to 35.5, with a mean of about 30.34. I would say about 30 or 31 would be the mean, and the range would be 25.3 to 35.5. But again, here I would like to specify that these are studies conducted by different regions of the world. And I would still feel that every laboratory using the parameter should do a good study to establish normal reference ranges for their own laboratory, because that is what ultimately counts. Like in India, we cannot use a reference range which has been established in the US, in the West, or in Australia in the East. So we should have our own reference ranges, and even within India, I would say that each laboratory should have their own reference range.
Thank you. Dr. Munshi, can we get low MCHr with normal CBC indices, and can it pick up impending iron deficiency anemia?
Not yet observed, as I would say, we haven't seen it yet. That normal CBC indices and a low MCHr, we would need more studies, I guess, to know whether we would be finding a low MCHr with normal indices. We haven't seen it, but then again, like I said, we need a much, much bigger study to be able to pick it up. And I'm looking forward to doing such a study, and hopefully, if we have enough data, we would be happy to publish it. And I'm sure then we can share it with you and you can share it with your viewers. Thank you.
Thank you. How much, let's see, let me rephrase this here. Let's go with this question. Is there any additional reagent for the MCHr test?
Yes. The special reagent, there is a reticulocyte reagent which comes separately. So any analyzer which predicts anything to do with retics, whether it is percentage retics or reticulated platelets or IRF or reticulated hemoglobin, would need the reticulocyte reagent, which will help picking up all the reticulocyte-associated parameters.
Thank you. Okay, let's go with this question. How much does the cost of CBC increase when we include this additional parameter? Is it lower than the cost of chemical analysis?
Very good question. Again, in resource crunch countries, very, very important. The cost of CBC would be increased because of the additional reticulocyte reagent that has to be incorporated by the laboratory, but still less than the biochemical parameters that would be added, because the cost of the chemistries would be ceramine, TIBC, ferritin. So if you put that and along with the special biochemistry parameters which any lab would test, definitely it would be cheaper to do it on a CBC with a retic mode because the cost wouldn't go up so much. And ultimately, it's not only important for diagnosis, but it is also important to monitor therapy of the patient. And therefore, it would be important to do it by a CBC. So you're not only giving a quick turnaround time, lesser draws, lesser cost to the patient, and monitoring therapy after institution of therapy for the patient. So I think overall, yes, even if you increase the cost of CBC, it would still suffice to be less than what would cost by adding biochemistry tests. Thank you.
Dr. Munshi, are there any large Indian population studies available for MCHr?
Not yet. I mean, I've done a literature search, and I have not seen any huge population studies available in the Indian population yet. But again, like I said, looking forward to doing it, and hopefully if we are able to do it, we may be one of the first to do such a population study, unless somebody else is already doing it and is going to publish it soon. We'll have to wait and watch for the next few years, because you see, these are very new parameters in the market. Not many people are exposed to these new parameters. So once the laboratories get used to working on these parameters and their confidence is built up, I think then the laboratories will be picking up these parameters to do population studies, and we will be seeing some, data coming out into the market. So we'll have to wait and watch, but being positive, we should be seeing some soon. Thank you.
Excellent. Thank you. Now, Dr. Munshi, is there a difference between MCHr values age-wise in a comparison between a child and an adult?
Again, that needs to be established. Like I said, we don't have enough studies. And so far, like we in our lab studied only on the adult population. So likewise, once our confidence is there now, like we are sure about doing it in the adult population, I think we'll have to extend our studies across not only different ages, but different population groups to come out with specific facts. So as of now, not yet established. Thank you.
Thank you. And we have so many great questions coming in. I want to remind our audience that those questions we are not able to answer to today, and those questions that come in during the on-demand period, they will be answered via the contact information you provided at the time of registration. Okay, let's continue in our live Q&A here. Dr. Munshi, have you seen any correlation between RetHE and MCHr?
Well, I haven't studied both the instruments together, but very good question, because we've just got the other instrument, and maybe we in our laboratory are fortunate that we have both the options of MCHr and RetHE, and maybe in future we may have a comparative study to compare the two. So far we've only studied the MCHr parameter. But yeah, very good question, that we should have a correlation established in our laboratory between RetHE and MCHr. And maybe I can share it with you later on in a year or two to let you know how it compares. The journal studies that we have, like I mentioned earlier, the American Society of Hematology study where RetHE population and mean of the RetHE for normal and iron deficiency showed an overlap of the ranges, whereas we had a distinct difference in the ranges on MCHr. So that we have published data already, which people can refer to. But yes, maybe some lab like us can do a comparative study and then come out with more specific answers to this question. Very good question. Thank you.
Dr. Munshi, can we reflex MCHr to low hemoglobin in an instrument?
Sorry? Can we reflect, did you say MCHr to low hemoglobin in the instrument?
Yes.
Is that the question? Oh, yes.
Correct.
Yes, we can. We can. Yes, we can. And that's one of the positives.
Are there controls available for the parameter? Like, what is your CV and reproducibility?
Yes, the controls are available. And from Abbott, I don't think there are guidelines CV. We don't have the CV or reproducibility yet. But I know the controls are available. And I think, again, the labs will have to establish their own CV for the control once they have. I don't remember my CV offhand. But I can tell you, maybe later on, I can message you and you can share it with the person who's asking the question. Thank you.
Very good. Thank you. Now, Dr. Munshi, what are the causes of false negative, positive MCHr in your experience so far?
Good question. Very good questions coming through, I must say, Christy. The studies done so far that we've done, like in our laboratory that I have seen, so far, no false negative or false positives observed, but a bigger study probably will highlight if we get any false negatives or false positives, which also includes interference with hemoglobinopathies. Supposing we have a hemoglobinopathy and we have a lot of NRBCs, we will have to establish and see whether there is an interference with the MCHr for such patients. So false negatives and false positives will be thrown up when we see such patients. And we will be establishing that over due course of time. Thank you.
Now, Dr. Munshi, as we were speaking about controls just a moment ago, how many levels of controls are available?
There are 3 levels of controls available for this, like for any other hematology parameter. Thank you.
Thank you. Now, are there any changes observed in newborn and infant values?
I think this is the same as what we went over a little earlier, that studies have been established in adult population. We don't have data on newborn or infant values, but if we want to win the confidence of pediatricians, it is very important, especially I appreciate the question, because in the pediatric population or neonatal population, it is difficult to get blood drawn. So if we can cut down draws for the child, it will be very important for pediatricians and neonatologists and we would be of great help to them if we can establish MCHr values in a neonatal or a pediatric population. So I think we will have to extend the study and divide the population into neonates, and even in the pediatric population, we'll have to probably divide it into 2 categories between 5 and 14, so that we can help them with normal ranges or reference ranges of MCHr in that population. But as of now, no. But very good food for thought. Thank you.
Thank you, Dr. Munshi. And I believe we have time for one more question. Would concomitant hemoglobinopathy or a hemolytic anemia with raised reticulocyte NRBC affect the values of MCHr? How will interpretation vary in such cases? For example, a thalassemia patient having iron deficiency.
Oh, thank you. Again, I think I just answered that a couple of minutes back, where we were talking about false negatives and false positives in MCHr, where I mentioned that hemoglobinopathy, especially thalassemia major, where we may see a lot of NRBCs, may reflect and give us a correlation, whether it is a false negative or a false positive MCHr. But we'll need to study thalassemia major patients who are undergoing hemolysis and then establish the MCHr values. You know, today we are in an era where thalassemia major patients are very well transfused, and we rarely see a patient who comes with acute hemolysis. But I think it's a very important question, and if we correlate this with the previous question on false negatives and false positives, we must run MCHr in patients with hemolysis, be it thal major or any other acute hemolysis, and then see the correlation for MCHr value and see whether we are getting a false negative or false positive in such patients. So we will have to establish data on that and then come out with more specific answers. Thank you. I hope that answers the question.
Thank you. And let's squeeze this one question in real quick. What about MCHr in dimorphic anemia?
Dimorphic anemia, again, I think that's a very valuable point to validate. We need to validate all these different population studies, because in a dimorphic anemia, we are going to see a mixed population. So we may get a false negative MCHr. I have not established this in my study, and I think we will have to look at dimorphic anemia, because if you're going to have a mix of population, we may or may not see a low MCHr. So I think this is, again, food for thought, and I think we should have another webinar maybe a year down the line, where we have more specific studies on all the questions that have been asked. Wonderful questions: pediatric population, hemoglobinopathies, dimorphic anemias. I think these are very important real-life situations where we will need to do studies for establishing reference ranges of MCHr and, interestingly, come out with answers for all these specific conditions in a year or year and a half and discuss it again. I think it's an excellent forum for all these answers. I think that's all that I can say for now. Thank you.
Thank you, Dr. Munshi. Now, before we go, do you have any final comments for our audience?
I can only say that this has been an excellent audience, and with the kind of questions that we've got, it's been so interesting and given so much food for thought that I must congratulate the audience for coming out with such wonderful questions. So I think it has been a wonderful interaction, and I really look forward to doing these specific studies in the coming year with all the questions that have been thrown to us and to me. And I hope to come out with positive answers at the end of the study that we may be doing in our laboratory at the end of the year. So I must thank you for organizing such an interesting webinar, and the audience for being so interactive and so good. Thank you so much. It's been a wonderful interaction and a very pleasurable meeting for me. Thank you.
And thank you, Dr. Munshi. And I, too, would like to thank the audience for joining us today and for their excellent questions. I do want to remind our audience that those questions we did not have time for today and those that are submitted during the on-demand period will be answered via email to the contact information you provided at the time of registration. I would like to once again thank Dr. Munshi for her time today and her important contribution to infection control. We would also like to thank LabRoots and our sponsor, Abbott Diagnostics, for underwriting today's educational webcast. This webcast can be viewed on demand, and LabRoots will alert you via email when it is available for replay. We encourage you to share that with your colleagues who may have missed today's live event. That's all for now, and we hope to see you again soon. Have a great day.
Thank you.